So my name is Diana Stafiy. I am also endocrinologist. I would like to show you my case. So actually, Thyrotropinoma hiding behind the mask, name of my problem, because it's also really a problem in our world. Actually, it's about 1 or 2.5.8% of pituitary adenomas, condition in which increase of normal secretion of TSH combined with increased levels of free thyroid, triaterinin, and thyroxine. TSH secreting adenomas occur at any age, most often in people as 30, 60 years, which occurs frequently in men and women. Actually, it's also hormone axis where we can see where TSH can stimulate triaterinin and thyroxine, and we have negative feedback. And this hormone should be decreased. But in case of Thyrotropinoma, feedback fails and all elevated. In my case, which I want to present, if a woman 37 years old with palpitation, goiter, sweating, decreased performance, 10 kilograms weight loss in 2 months, and increase in blood pressure till the 185, panic states and weakness. It looks like primary hyperthyroidism, but it isn't. In the hormone profile, we can see high level of thyroxine, and TSH should be, of course, lower, but it isn't. We also had ultrasound. The volume, like typical reaction, also high. We have some changing in structure of the gland, and fine needle aspiration. We also have just inflammation problem. We also had scan, which also has like a gold standard for Thyrotropinoma or adenoma, but again, we didn't find any problem there. So treatment strategy was based on the symptoms, laboratory tests, thyroid, ultrasound, all the things, and we diagnosed a hyperthyroidism with diffuse nodulous goiter grade 2. Treatment prescribed, we took this strategy, Tarazole, 20 or 30 milligrams per day for 2 months. During the treatment, it was possible to achieve the effect in normalization thyroid hormones. As a result, treatment with tarazole was cancelled. Here, I also would like to show you some screens from MRI. So we didn't achieve any good effect, which we provide, but we moved to another hospital, another country for future diagnostic. So thyroid scintigraphy show us the extra functional activity of thyroid gland, and MRI, more important for us, it was diagnosed pituitary adenoma. Like you see on the screen, it was size 7 millimeters on 7. So again, we took profile of hormones, and here, like you see, we have much more increasing for triaterinin and thyroxine. For another hormones of pituitary glands, it was absolutely normal. And again, here, TSH should be less, but it's absolutely normal. So next step was in the hospital, where we also had one more time MRI, where again, it should be diagnosed adenoma, but a little bit more size. It was not 7, but 9 millimeters in size. So, and the same problem with thyroid gland hormones. So the way for treatment, we took another like this. We use somatostatin analogy therapy. It was lanreotide, 120 milligrams. It should be given per one time per 28 days. So in general, monthly. Actually, like a result, the reducing of symptoms was reached, but again, when our patient gave this therapy one more time, it was in October, it was terrible pain in the stomach, so we need to cancel this treatment. And at this time, this patient gave this another way for operation, for surgery therapy. So in general, we need to say that 6 months after the onset of symptoms, we have this transnasal removal and endocellular thyrotropinoma by surgery. So outcome of this therapy. In the early post-operation period, positive dynamic were noted, decreased TSH, like you see, normalization of thyrotropin, significant decrease in thyroxine, no date for secondary renal insufficiency, no symptoms of hypercortisolism, again, no polyuria, polydipsia, and no liquoria. So actually, we also, in 1 month after surgery, we had this report about 100% neuroendocrine thyroid trophic tumor. So I need to say that it's my patients. Now we also monitor all these laboratory tests and condition. In general, we have only weakness and anxiety a little bit, but in general, the condition is absolutely normal. So now in we also had some tests, and we see that TSH right now it's a little bit low than normal, but actually we also can see something so hyperthyroidism. So maybe it will be also like secondary hyperthyroidism after all this movement, women surgery. But actually, my purpose was show that it's also a role case in our world, in our practice, because actually in my practice it's the first one. But as I can say that in the world, we also diagnosed about 500 cases of thyrotropinoma. Mistakes is differential diagnosis lead to insufficiency thyroid surgery or radiothyroid therapy. We also can see that sometimes we can see that it can be, again, correct diagnosis can be happened after 5, 6, 7 years after onset of the symptoms. But here, like you see, the surgery was done after 6 months after beginning of all the symptoms. Always correct clinical symptoms with test results. Consider thyrotropinoma if the TSH is low normal, or it also can be high. And MRI of pituitary gland with contrast is more important than CT. As I said, it's also gold standard for finding this problem. But actually, in my case, it was absolutely unhelpful because only MRI with contrast, it was crucial. So early detection is better outcome, it's always, and coordinate care is required, endocrinologist, radiologist, and neurosurgeon. Thank you.